Good afternoon, everybody. My name is Sherry Buri. I'm a hepatologist, and I work at the Istituto Nazionale Tumours in Milan under the guidance of Professor Mazzaferro. EASL is back in Milan after 16 years. During this very long period, actually, the whole management of primary liver tumors has been overturned, not just once. So it's a real pleasure to have it here in Milan. As Milan has been my home for quite some time, it really was an honor for the city to have such a thriving and successful meeting. My role today, and I would really thank the EASL Governing Board for giving me this occasion, is to walk you through the liver tumor experience here at the EASL meeting. Here you can see the primary liver cancer experience, the agenda. The agenda was quite full, was very busy. And what I would like to show you at the end of this presentation is that all these topics managed to blend together in order to create a fine-tuning, exactly like it happens with different instruments inside an orchestra. There has been also innovation, and there has also been technology. There have been several scientific communications of very high level with posters and oral communications. We went through 250 approximately liver tumor communications, and just to tell you that 20% of these were mainly focused on immunotherapy and more than 30% on prediction of response. As I said before, there were several really good scientific presentation and communications. Unfortunately, for the sake of time, I could not report all of them. I had to choose for some of these. Anyway, the main object was immunotherapy. I would first like to start this presentation reporting this slide from the opening ceremony, which just reminds us about the epidemics of steatotic liver disease. Now, we all know that this is becoming a major problem, but if we see this very wide population epidemiology-based study, you will see that actually the etiology of MASLD is really becoming the real cause of HCC, and this is still quite shocking. Especially metabolic risk factors may be drivers for HCC. But this French study on approximately 300 patients treated with atezolizumab showed us and cleared the field that immunotherapy is also useful in this particular etiology. That means metabolic-associated steatotic liver disease. So we've cleared the field on any doubt on the use of immunotherapy in this particular etiology. Immunotherapy was the focus of the really first meeting on Wednesday itself. Amazing panel of experts which focused on the results of the most important trials recently positive in immunotherapy for HCC. That means the IMbrave 050, the Emerald 1, and the Checkmate 9DW. This EASL studio, which was held here at the arena, actually ended suggesting us that we have to carry on to biopsy our patients because we have to look for biomarkers. The main important point is that we still have very little knowledge, if not no knowledge, of the various mechanisms that govern resistance and response. That means that we have to look for this knowledge. We have to look for the processes that help us to bypass resistance, and we have to probably look for other treatments. Like Professor Lovett says, we are getting very close to the exhaustion, allow me this term, in immunotherapy combinations. In order to do this, I would like to report this very elegant study. They actually tried to derive with single-cell RNA-seq gene signatures, which could predict response to immunotherapy. The bottom line of the study is that within responding patients, the authors managed to describe two different mechanisms of action. The first mechanism of action, totally expected, is the immune-rich mechanism of action. That means the hot tumors with CD8-affected T cells and other pro-inflammatory populations. And these represent 50% of the responding patients. Now, what is amazing is that the remaining population of responder patients are immunologically cold patients. That means that they do not have an immune-rich tumor microenvironment. But what they do have is a particular expression of the angiogenesis pathway, and they have hyperexpression of VEGF and a low expression of NPR1, which we know to be correlated with the response to bevacizumab. That means that in this particular context, bevacizumab is not a synergic drug anymore, but it is an additive drug. Talking about the mechanisms to bypass resistance, I would like to report the study coming from Vienna. The other preliminary results of the FAB-ACC pilot study. That means 6 patients who underwent fecal microbiota transplantation once they progressed to atezo-bev, and they received the stool from donors with an amazing complete response to atezo-bev. The strategy seemed to be safe, and it did give a disease control rate of more than 80%, and this was really very interesting. The second day of the Congress was mainly concentrated on immunotherapy in the earlier stages of disease, as a neoadjuvant and as an adjuvant treatment. Again, a very amazing panel of experts, starting from Professor Vogel, back from ASCO 2024, trying to explain to us the advantages and the disadvantages of adjuvant and neoadjuvant treatments. Professor Mazzaferro went through the survival recurrence curves after surgical resection. He showed us that also in metabolic patients, we have a double peak pattern of recurrence, but differently from what happens with viral patients, the second wave seems to be anticipated compared, as I said before, to the standard of viral etiologies. Professor Mazzaferro went in depth trying to analyze the 2 positive studies of adjuvant immunotherapy after resection, in particular the IMbravo 50, which had a positive recurrence-free survival after surgery for high-risk patients. The bottom line concept is that we have to consider adjuvant therapy, which has been for a very long time an unmet need. But we need to do this with caution because, as you see on the left part of the screen, we have several criteria for high risk, and this may be still confusing. And we need to do this with caution because we do not have just to extend the resection indication just because we have a systemic therapy to follow. And at last, as we have results on recurrence-free survival but not on OS, we need some more convincing recurrence-free survival surrogacy in able to adopt immunotherapy as an adjuvant treatment. For what regards the IMbravo 50, I would like to report this very interesting communication coming from Bologna. In the particular context of low-risk patients after resection, they tried to stratify this particular category, and they found with liver stiffness more than 15, patients who were worth treating with an adjuvant systemic immunotherapy, even though at low risk. And this was really very important. Professor Bargellini showed us the strengths and the weaknesses of combining local regional treatments with systemic treatments before resection. We are now starting to develop this concept in the downstaging process, in the stage migration process towards liver transplantation. This morning we saw the preliminary results of the ImmuneXXL study, which is a prospective study involving immunotherapy before liver transplantation. And you can see from the survival curves, adding on transplantation to a successful downstaging achieved with immunotherapy can give some very safe and very good results, which of course needs further confirmation. Again, talking about immune checkpoints and transplantation, I'd like to report this scientific communication coming from France, which actually challenged the dogma of using immunotherapy after liver transplantation. It can be done upon HCC recurrence, or it can be done for de novo tumors, even though you have to very carefully balance what is the immunological benefit and the immunological risk you're giving to a patient, oncological benefit and immunological risk. And of course, you have to be very careful of what your immunosuppressive regimen is. We had a very interesting session on treating patients with liver dysfunction, mainly Child-Pugh B patients. Again, a very interdisciplinary panel of experts. And the bottom line was that patients with liver decompensation have to have a multi-parametric evaluation, first point. Second point, whenever we have a patient with liver decompensation, we have to adopt a personalized treatment, keeping in mind that liver transplantation is always the best cure we can give to our patient. In this particular context, I would like to report two studies, one coming from Rome, and underlying the significance of liver decompensation in the treatment with atezolizumab. In this particular paper, we can see that Child-pugh B patients have a lower overall survival compared to the compensated population, and despite the possibility of decompensation is higher, actually the main driver of the outcome of the patient remains the oncological feature. And the last curves show us a very interesting fact. These patients do decompensate, Child-pugh B patients do decompensate, but the probability of decompensating is higher, but they do also recuperate liver function quite easily. And if we do resume immunotherapy to these patients, their survival is very similar to patients who never decompensated. This paper, instead coming from Bologna, showed us that hepatic decompensation represents the main determinant of death. These were patients who started treatment with a good liver function and decompensated throughout the treatment. The most important feature is that we do realize that liver function is a competitive risk of death when we talk about HCC, and that future randomized control trial should include hepatic decompensation among secondary surrogate endpoints. We have had several interdisciplinary meetings, starting from the meeting on Thursday and again carrying on Saturday morning, where we had a thorough overview of tissue and circulating biomarkers. The most important concept is that the pathomolecular diagnosis made by the pathologist can help clinicians to refine the management, because can give us a wide idea of the condition of the tumor. And Professor Bruno Sangro reminded us that biomarkers are very important, but unfortunately, they're not the solution. They are only a part of a big integration of data coming from various sources. And that means that probably at that point, AI can help us in this. Reporting what we know about biomarkers and predictive of response, this very elegant paper coming from Freiburg, they actually did try to apply spatial single-cell profiling to all the immunological cells of the tumor microenvironment. And they managed to identify 3 particular immune phenotypes, which they call immune neighborhoods, each one of them with a specific composition of immunological cells. And they actually managed to say that these particular immune phenotypes resemble what we know about the tumor microenvironment: immune-rich, immune-depleted, and immune-exhausted. And these particular immune neighborhoods can actually correlate with progression-free survival. So the message is that this particular spatial immunophenotyping can describe the heterogeneity of the tumor microenvironment and can represent a potential marker for clinical decision-making. If we do not have the biopsy, we can try and rely on what is called the liquid biopsy. This is again a paper coming from Germany and showing us that we can actually look for immune checkpoint expression on tumor-derived circulating extracellular vesicles. The main endpoints, which were actually all achieved by the authors, was to validate and confirm the presence on extracellular vesicles of the expression of checkpoint molecules, to correlate them with the tumor biopsy, and to identify predictors of response. And as you can see, they managed to predict response according to the expression of checkpoint molecules on extracellular vesicles. Again, talking about extracellular vesicles, but this time not in the blood, but on the bile. This particular paper showed us that it is possible to apply this method in order to perform an early diagnosis of cholangiocarcinoma in PSC patients. This is really a slippery slope because usually there is an overlap between the features and the symptoms between cholangiocarcinoma and PSC. And so it is very difficult to try and spot out patients with cholangiocarcinoma. We can try and do this on the extracellular vesicles in the bile, which are directly in contact with the biliary epithelium and can actually be collected easier with ERCP as they go through the biliary tree and through the tumor itself. And the authors managed to conclude that we are not just able to detect early cholangiocarcinoma, but also to try and predict who will develop cholangiocarcinoma. This can dramatically change the management of our patients because we can early forward these patients to liver transplantation. This last paper I would like to report underlines the need to look for other treatments. This is Claudin-1. It's a transmembrane protein which is expressed by the tight junctions, and it is a marker of cell proliferation, stemness, and plasticity, and a marker of the transition between the epithelial and the mesenchymal stage. Now, it is really expressed in cholangiocarcinoma, and if we do manage to develop a monoclonal antibody against Claudin-1, we should be able to stop this oncogenetic process. I do not want to beat around the bush. I would like to tell you that the keyword of the liver tumor experience at EASL 2024 that blends together all this topic for me is prediction. A big effort and try to predict who will develop ACC in non-cirrhotic patients, a very big effort in trying to predict the risk of HCC recurrence after curative treatments or after local regional therapies, try to predict the risk of post-treatment decompensation in the particular subset of immunotherapy, trying to predict the risk of developing cholangiocarcinoma in high-risk environments, to predict the response to immunotherapy and the resistance to immunotherapy, both in hepatocarcinoma and in cholangiocarcinoma. So I think that the streets of Milan finish here this morning, where Bruno Sangro did give an anticipation of the new clinical practice guidelines on liver tumors, an enormous amount of revision, an extreme amount of evidence-based data, and a thorough reasoning in order to give us the new guidelines for liver tumors. So we've ended EASL 2024. I really hope you enjoyed this meeting, and I really hope the next road brings you to the EASL Liver Cancer Summit in France next year in February. Thank you very much for your attention.